Hello, I'm Steve Strakowski. I'm a professor of psychiatry and vice chair for research at Indiana University School of Medicine. I also work as associate vice president for regional mental health and a professor at the University of Texas in Austin, where I support projects in both cities. Today, what I want to talk to you about is bipolar disorder. Bipolar disorder is a very common psychiatric condition. It affects somewhere around 2% of the general population, but often constitutes as much as even 30% or higher of a typical psychiatric practice. It's for people who experience it can be truly mystifying, and it's often misdiagnosed or misunderstood. And so today we're going to briefly just kind of go over how do we recognize it and what are some of the things that help us think about it when you're encountering this as a diagnosis or in yourself or a family member. First of all, bipolar disorder, the name is a little misleading because it's actually defined by the occurrence of something called mania, which we'll talk about more in a second. A single manic episode can define someone as having bipolar disorder, and that is how the diagnosis is made for a condition called bipolar disorder type 1. Bipolar disorder type 2 is similar, but it's defined by hypomania, which is a somewhat less disabling form of mania, but then also requires the presence of depression at some point in the course of illness to officially make the diagnosis. And that one can be a little confusing. The two conditions are about equally common and sort of divide that 2% I talked about earlier. Even though mania in bipolar 1 disorder defines the condition, in fact, the course of illness is still, in most people, dominated by depression. About 80% of people who experience mania will have a depressive episode sometime, and the percent of that may even be higher as you stretch out over an entire lifetime. But what that means is there are a few people with so-called bipolar disorder that only experience the manic pole, if you will, which is why the name's sometimes misleading. The old name was manic depressive illness, which is one that I think is probably more descriptive, but it's not what we call it at this time. Mania is defined very specifically by the DSM-5, which is psychiatry's code book for making diagnoses. And I'll give you these guidelines, and then we can talk a little bit about them. First of all, there needs to be at least a week of a persistent mood disturbance. Typically, mania is thought to be just a euphoric condition, and that can be true, but it can also be less euphoric, but more elevated mood or irritable mood or labile mood, which is very common, where you just kind of bounce from euphoria to frustration to depression through the course of illness. And yes, indeed, depression can be part of mania, which is confusing, but that's true. So really what we are looking for is a persistent extreme mood disturbance that then is accompanied by grandiosity, increased reward seeking. Hyperactivation for reward is kind of almost a defining characteristic, where people have increase in energy, but it's motivated towards accomplishing something, which the grandiosity goes along with. It's kind of why I need to be doing this. Then that's accompanied by further evidence of kind of exhilaration with pressured speech, racing thoughts, a lot of distractibility, and ultimately risky and impulsive behaviors, which is what often will get people in trouble. In its extreme, people with mania can develop delusional thinking, false beliefs, or hallucinations. And in fact, those are fairly common as mania progresses. Hypomania, which we talked about briefly earlier, is a less severe form of mania. It's actually all the same symptoms, exactly the same, except that it's not functionally impairing and there's no delusions or hallucinations. So mania requires you to have functional impairment and that you can't do what you normally would do. Hypomania, same set of symptoms, but you're still able to kind of carry on life. Ultimately, when making the diagnosis, we have to rule out other potential causes. Being high on cocaine, for example, may look like this, or abusing stimulants or some other drugs of abuse. Rare cases of strokes or brain tumors can occasionally cause these syndromes. Those kind of things, the medical things, tend to be in older adults. So bipolar disorder defined by mania, affecting about 2% of the population. Once you've had a manic event, you have an 80 to 90% or more chance of developing a recurring mood disorder illness, which is what we call bipolar disorder. So in most cases, if you've developed mania, you will go on to develop bipolar disorder. Once it's established, it continues. And so we have to treat it and manage it throughout the life cycle until we find solutions and cures, which we unfortunately don't currently have. Most people's mania is easier to manage than their depression. And as I mentioned, that much of the course of illness is managing depression, which sometimes leads to misdiagnosis when the manic part is missed. At least 25% of people with bipolar disorder will attempt suicide, and some studies suggest as many as half. And so it is the psychiatric condition that has the highest rate of suicide, somewhere between 10 to 15% of people, usually early in the course of illness, but sometimes it can also occur later. It's a disorder of development, brain development in adolescence. And so the vast majority of cases will start between ages 15 to 25. And it's also very genetic, so that there's an 85% heritability risk. So if we took identical twins and got a whole bunch of them and looked at them, if one twin has bipolar disorder, 85% or more of the other shared twin also will. And so when we're looking for bipolar disorder, thinking about a diagnosis, we really expect to see a strong family history of illness. Very unusual to have no family history, although unfortunately people don't always talk about their mental health histories, and so sometimes people just simply don't know about it. And then it usually starts before you're 25, and it becomes increasingly rare to start after 30 or 35. If it first presents in your 40s or 50s, we have to worry about some other medical problem that's affecting the brain and creating this syndrome. Bipolar disorder, despite only being about 2% of the population, is the 6th leading cause of disability worldwide. So it can be a very significant medical problem. That said, most people, 80% plus, who receive effective treatment and manage their illness will live truly typical and normal, whatever you call it, lives and look just like everybody else. And so the illness doesn't have to prevent an individual from doing what it is they want to be successful, but it does require paying attention to it and managing it, just like other chronic medical conditions like diabetes, where people with diabetes have completely good lives and successful lives, but they have to take care of it. And so as people struggle with this condition, it's important to approach it positively and work with your treatment team to expect a good outcome. Bipolar disorder almost inevitably requires medication management. In fact, I don't believe it's possible to ultimately get a best outcome without medication. And although the goal is always to manage it with one medication, most people end up on somewhere from 1 to 3. I actually have a belief that I've published in books that I've written, that if you're going past 3 medications just for your bipolar disorder, then you need to rethink what you're doing, you and your doctor. With medication, psychotherapy is critically important. These illnesses are very disruptive. They impair interpersonal relationships, jobs, just generally succeeding. And so having psychotherapeutic help, it can be very, very beneficial. And in fact, it's probably essential. When faced with these symptoms and you're wondering about, do I have bipolar disorder? Does my family member or this friend? There are a number of other conditions that are often confused with it. Depression, major depression, of course, is often part of bipolar disorder and really is distinguished only by the presence of mania. ADHD has a lot of distractibility, and particularly in young people can be very hard to determine, but it tends to be continuous and chronic, whereas bipolar disorder is episodic. They are not mutually exclusive, however, so you can absolutely have a history of attention deficit hyperactivity disorder and bipolar disorder. The psychotic symptoms of mania can look like schizophrenia. The two are mutually exclusive, so you really ought not to carry both diagnoses. And then a number of other conditions, drug and alcohol abuse, can mimic the symptoms. And trauma and post-traumatic stress can also mimic symptoms with impulsivity and extreme mood states. However, mania, when properly recognized and diagnosed, is a fairly specific syndrome that is relatively more defining than most psychiatric conditions. And so it really requires paying attention to those symptoms. That said, like I mentioned, once the diagnosis is made, working with someone who understands how to manage it, someone with bipolar disorder should go into treatment expecting to be able to manage the condition and really live the life they want to live while paying attention to the signs. And so I know that's a lot of material in a short time, and I really strongly recommend going to good websites that are by reputable medical authorities to get more information, to educate yourself as much as possible about this sometimes very mystifying, but also very treatable condition. Thank you, and I hope this was helpful.